I'm going to talk briefly about basic airway management in terms of manual position of the airway and then orals and nasal airways. Here's your standard head tilt chin lift. Probably also could do some head extension by placing something under the shoulder, something under the head there to move the head anteriorly a little bit. Would probably help some, but this is your pretty typical head tilt chin lift maneuver. Jaw thrust also works nicely, helps you when you're doing mask seal. Caution you on very small people, as in the small picture there, to be sure that you have fingers on jaw and not on soft tissue or pressing on carotid arteries. Oral airway sizing is very simple. You go from the corner of the mouth to the angle of the jaw, and you see in the center picture some various types of oral airways, and the picture on the left are the standard color-coded ones that we're using at this point. Here's a good color-coded size. You'll notice also that there's some overlap there in terms of where we carry these in our EMS packs, as well as some of the sizes that will fit, and some general reminders. This is a published document that's available in monthly training sessions, as well as for your StationsNet. Oral airway insertion is very simple. The airway is inserted in an inverted manner until you're behind the tongue, so you don't push the tongue posteriorly to push the tongue back on the back of the throat. Get the airway in the mouth and essentially behind the tongue, and then you're able to flip it around to where it goes in the position that you want it to be. If the oral airway keeps coming out on you, then it's probably too small. The large airways, the size that's the largest the patient will tolerate, is probably your better choice there. But the airway should stay in position. It should not keep coming out on you. If that's happening to you, then you should probably switch to a larger one. Nasals are another option. Several pictures here showing how to size. There's 2 or 3 theories out there. They're all acceptable. Essentially place the airway where it's going to go. It's going to go from the nostrils and then back to the angle of the jaw. We like to insert on the right side if that right nostril is an option for you. So lube the tip very liberally and then place it in the right nostril. So the right nostril is the right one. That's the right side to go through. If you can't make it through the right side, and many people, myself included, are completely occluded on that side, could not pass a nasal airway, then you can switch to the left side. And in that case, go ahead and insert it in this normal curvature here. There's no need to flip it over to worry about the bevel of the going against the septum, because as you rotate it into position, you're going to do more nasal trauma than if you just left it alone. So the right side's the right side. That's the right way that it goes. If that won't work, then just simply switch over to the left side. This is also called a nasal trumpet by some folks. And so the bell of the trumpet, the proximal tip of the airway, goes up against the nostril, as you can see in that bottom picture. Orals and nasals will help you maintain the airway, will help you with your head tilt chin lift, but they don't replace the need to continue doing head tilt chin lift or jaw thrust. So they're an adjunct, they're not a replacement for manual maneuvers. And you should use an oral or a nasal anytime we're doing positive pressure ventilation. So if you have a bag valve mask in your hand, the patient should have an OPA or an NPA in place. NPAs are well tolerated by patients that have a gag reflex. Oral airways are not well tolerated by anyone with a gag reflex. So we're going to assume that a patient who's not responsive to your nail bed painful stimulus pressure probably does not have a gag reflex, and the OPA would be an option. But NPAs are an option with anyone. Conscious patients can walk around with nasal airways in place. So start with either or, an oral or a nasal, based on the level of consciousness of your patient. It's acceptable to use an oral and a nasal together. It's acceptable to use 2 nasals together. You can use an oral and 2 nasals if you want. There's nothing wrong with that, and it may help you. So oral and nasal airways, manual airway maneuvers, they all go together. We can't use one without the other when we're doing positive pressure ventilation.